Hi, everyone. In this podcast, we're going to talk about what is evidence-based care. So welcome to today's podcast. In our last session, we talked about how I started evidence-based birth and why I got into writing about the research on childbirth. In today's podcast, we're going to talk about what is evidence-based care. Is it a specific way of giving birth? Is it a checklist? Really, what is it? What is it not? Well, first, let's talk about the old way of doing things in medicine. It used to be that medicine was practiced entirely based on a doctor's clinical opinion, experience, and unsystematic observations. I'll give you an example of something that I read from a 1950s obstetrics journal. A physician was writing about how he decided to manually remove a woman's placenta. In other words, after the woman gave birth, he physically reached up with his hand into the woman's uterus and removed the placenta with his hand. He said it went well, so he decided to do it with all of his patients. 200 births later, he wrote, quote, "This is a safe and beneficial practice," end quote. These decisions that he made were based on his opinion, his experience, and really unsystematic observations, because although he said everything went well, he didn't systematically record the complication rate that happened with this practice, and he didn't compare this practice with other women who did not receive this practice. We now know that this practice, manual removal of the placenta, is not something that should be done on healthy women as it's extremely painful and can cause complications. This type of practicing medicine also used to happen in midwifery. For example, some of the older midwife textbooks talk about giving women enemas, giving them something to make them poop a lot right before they gave birth. Another example might be a midwife who does water birth with her clients and says, quote, "Water birth decreases the number of tears," without specifically talking about the research evidence on the rate of tears with water birth. So using unsystematic, non-recorded clinical experiences as kind of the rationale for why you might do something instead of looking at the research evidence. Now, the term evidence-based medicine was first used in 1990. Now, I do want to say that although doctors were the first ones to use the term in 1990, that Florence Nightingale, the legendary nurse, first started using statistics to help base medical decisions in the 1850s. When she arrived at a British military hospital in Turkey in 1856, the mortality rate was sky high. She started keeping statistics and used that evidence to discover that poor sanitation and poor sanitary practices were the reason for so many deaths during that war. She used that evidence to save many, many lives. Fast forward to the 1990s, and doctors at a Canadian medical residency program first used the term evidence-based medicine in an informational document for medical residents. In that document, they said, quote, "The goal is to be aware of the evidence on which one's practice is based, the soundness of the evidence, and the strength of inference that the evidence permits," end quote. In 1991, these same physician educators linked up with physicians in the United States to form the first international evidence-based medicine working group. They published an article that described evidence-based medicine, and they called it a complete shift from the traditional way of practicing medicine. In contrast to the traditional way of practicing medicine, evidence-based medicine says that intuition, unsystematic experiences, and just using pathophysiology are not sufficient grounds for making clinical decisions. And instead, we need to also look at evidence from clinical research. This does not mean, however, that intuition and clinical experience should never be used, only that we should also include the research evidence in our decision-making. In 1996, David Sackett, an American-Canadian medical doctor and pioneer in evidence-based medicine, published a classic book about evidence-based medicine. In Sackett's writings, he says that evidence-based care is the integration of best research evidence with clinical expertise and patient values. So this means that evidence-based practice is a triad, or I like to call it a three-legged stool. It's a combination of research evidence, the clinician's experience and expertise, and the patient's values and preferences. In other words, evidence-based care is having full, accurate information, evidence-based information to help you make decisions, being cared for by a trained provider who pays attention to the evidence, and care that is tailored to your preferences, goals, and values. So let's take a look at the first leg of that three-legged stool, and that is research evidence. One of the important things that a lot of people don't realize is that there are different levels of evidence. Researchers have tried to rank evidence in order from highest level of evidence to lowest level of evidence. These rankings are somewhat controversial, but systematic reviews are considered to be the highest level of evidence. A systematic review is something that combines information from many different research studies. An example of a systematic review are reviews from the Cochrane Library. The next level of evidence comes from randomized controlled trials. Now, in a randomized controlled trial, it's an experiment. So one group receives usual care or some kind of placebo, and the other group receives a new treatment. Now you're randomly assigned into one of those groups. So sort of like flipping a coin, you don't know ahead of time which group the person is going to be put into. And then researchers compare the two groups before and after. The fact that people were randomly assigned to the groups controls for potential differences between groups. For example, randomized controlled trials on doulas are important. People may say things like, well, the people who chose to have a doula are more likely to have a vaginal birth because they're more motivated to have a vaginal birth. That may be true, but in a randomized controlled trial, people are randomly assigned to either have a doula or not. So that random assignment controls for the differences between those two groups, and you can no longer say it's just because they chose a doula that they have a higher vaginal birth rate. Another thing that's important to know about randomized trials is that often they are blinded. Blinding means that either the patient or the clinicians or the researchers, or maybe all three, don't know which group the patient has been assigned to. This helps eliminate bias in the study, but it's not always possible because some treatments are very visible. There are some drawbacks to randomized controlled trials. Like I already said, some interventions cannot be randomized. Some patients may have strong preferences and may decline to be in a study. Other researchers may have difficulty getting ethical approval because the treatment is already standard practice. Also, some randomized trials are just too small to look at rare complications, and they may be done in carefully controlled research settings that may not translate to real-world settings. But in general, we tend to look at randomized controlled trials as a high level of evidence. The next level of evidence on the hierarchy, moving down, is observational evidence. As I said earlier, a lot of things in maternity care cannot be randomized. And in those cases, we often turn to prospective studies. Prospective studies are when you enroll someone somewhere in pregnancy and you follow them throughout the birth and hopefully afterwards to find out what happens to them. You can think of pro as moving forward. So a prospective study means moving forward in time and following people along as you go in the study. Now, although prospective studies are considered the highest quality of observational research, you may or may not have a comparison group. For example, there are a lot of prospective studies on water birth, and some of them may not have a comparison group to compare people who chose water birth with those who chose water birth but for some reason did not have access to a tub. Another type of observational research are case control studies. In a case control study, they compare people who have a disease or a certain outcome of interest, such as a certain type of complication, with patients who do not have that complication. And they look back to see how frequently the different groups were exposed to different risk factors. And these studies, they're trying to figure out what things may have increased the risk of the people who experienced a certain outcome. Retrospective studies are considered a lower quality of observational research. Retro means backwards. So in these cases, they're looking backwards in time. Often these are medical record studies, so they may look at a whole bunch of medical records to see what happened to a bunch of people. The main drawback to this is that limited data are available. For example, you may figure out that a certain number of babies were admitted to the NICU, but it might be difficult for you to understand exactly why they were admitted to the NICU, because maybe those data were not collected on that specific medical record that they're using. Now, after observational research comes case reports. Case reports are considered one of the lowest forms of research evidence. A case report can be something like a letter to the editor in a medical journal, or an anecdote that is shared from one doctor to another doctor, or it can even be a formal written case study where a provider writes up everything that happened to a specific patient and publishes it in a journal. Case reports can be of good or bad quality. One of the problems with case reports is that there's no denominator. So what do I mean by that? Well, there's a numerator. There's one case that happened, but we don't know how common or rare it is because we don't know if that was 1 out of 1,000 or 1 out of 1,000,000. However, case reports can be useful for learning about rare events and just kind of figuring out what happened in this rare situation. Then finally, we have medical opinion. Technically, medical opinion is considered medical evidence. However, it is the type of evidence that is most likely to be biased, and it can be totally right, or in some cases, it can be totally wrong. There is a certain amount of uncertainty in medical decision making, and although medical opinion is helpful, it is not infallible. In other words, like I already said, it can be right some of the times, but it can be wrong some of the times. So that is a look at the first leg of the three-legged stool research evidence. Now, there is a really important caveat about evidence-based care and about the research, and that is that evidence alone is never enough to make a decision about your health care. When you're making a decision about your care, you must look at the potential benefits, potential harms, the costs, inconvenience, and the patient's values, goals, and preferences. The second leg of the three-legged stool is clinical expertise. It's so important to have a trustworthy care provider who is experienced in applying the evidence to your specific situation. A lot of people today think that they can just Google things and make healthcare decisions based on what they find on Google. Or they might find one specific research study and use that to make a decision about their healthcare. It's important for you to actually talk with your care providers about what you're reading online and about the research that you're considering, because a good care provider is going to help you make sure that that evidence and that information applies to your unique situation, given your clinical background and assessment. For example, someone may read the evidence-based birth article all about suspected big babies and think, oh, I don't need to do an ultrasound to check for a big baby because that's not evidence-based. But what if this person has gestational diabetes that's not controlled with diet? In that case, their care provider might say, hey, that research that you're looking at doesn't apply to people with gestational diabetes. So let's look at the research on gestational diabetes that's more specific to you. Finally, the third leg of the stool is patient values and preferences. As I already said, one of the core principles of evidence-based medicine is that evidence is not enough. And that's because when evidence is used alone without any input from patients, it can become like a bad dictator. This means that there really is no one single right decision for everybody. And that's because everybody's situation is unique. For example, the hot topic of epidurals. For some people, their values, goals, preferences, or unique medical situation may mean that they absolutely should not have an epidural unless it became truly medically necessary. On the other hand, you might have somebody who absolutely needs an epidural during labor based on their unique situation. And you have some people who fall into more of a gray area where they need to weigh the pros and cons, and their decision may differ based on different circumstances that they're in. Also, we each have our own underlying biases that affect our decision making. And much of the time, we're not even aware of our biases. There's a great book called Your Medical Mind by Dr. Jerome Groopman and Pamela Hartzman. In their book, they describe the difference between doubters and believers, minimalists and maximalists, and naturalists and technology lovers. Some of you who are listening to this podcast might be doubters. You might approach medical treatment or medical advice with skepticism. Or on the other hand, you might be a believer, where you believe that there is always a medical solution from your doctors for your problems. So doubters and believers are one of the categories that you might fall under. Another category that they talk about in Your Medical Mind is minimalists versus maximalists. A minimalist is something who wants to avoid treatment if at all possible. They think that less is more. One example of someone who's a minimalist might be someone who wants to avoid a labor induction if at all possible, and would only induce if there was imminent danger and severe need for the induction. On the other hand, a maximalist is someone who wants to control risk as much as possible. Their saying is, do whatever you can. A maximalist would gladly accept an induction at 39 weeks in order to prevent the extremely rare risk of stillbirth. And then you have naturalists versus technology lovers. A naturalist believes that nature is best, that you should leave the body alone, and that medications are unnatural and dangerous. A technology lover is someone who believes that science, modern medicine, and technology are the answers. An example of naturalist might be someone who believes that anything synthetic or artificial is dangerous to her or her baby. A technology example might be someone who wants epidural as soon as they go into labor, who believes that continuous electronic fetal monitoring is important and could save her baby's life, and who thinks that the more monitors and equipment are in the labor and delivery room, the safer she and her baby are. So I'd like to think about where you are on the spectrum. And if you're a professional, where are your clients on the spectrum? Are they a doubter or believer, a minimalist or maximalist, a naturalist or technology lover, or somewhere in between? Some people have told me that they personally might be a maximalist technology lover, but when it comes to birth, they're more of a minimalist naturalist. No matter where people are on this medical mind spectrum, it's important for us to remember the three-legged stool and remember that we still need to be providing people with evidence-based information. Also, it might be important to think about whether or not your mind and your provider's mind are a good match or a good fit. If you're a minimalist naturalist and your doctor is a maximalist technology lover, then it might not be the best fit for a childbirth situation. So in summary, we've talked about evidence-based care being a three-legged stool. It's having the most up-to-date research evidence. It's being attended by a care provider who pays attention to the evidence. And it's about care being tailored to your preferences, goals, and values. And with that third leg of the stool, we always have to keep in mind that everybody has biases, and it's important to know what your biases are up front and what your provider's biases are. What is evidence-based care not? Well, it's not cookie cutter care. It's not assembly line care. It's not having a care provider who ignores your individual situation or preferences. It's not having a care provider who practices based on worrying about their legal liability and ignores the research evidence. It's not when inaccurate information is given to you. It's not the overuse of treatments that, when used unnecessarily, have been shown to have more harms than benefits. And this is really important. I really want to stress that there is no right decision for everyone when it comes to their care. There's no universal checklist you can use to create the perfect evidence-based care experience. Each and every person who enters childbirth is an individual, and the best course of action may vary from person to person. The answer to any given medical situation during pregnancy and childbirth is specific to you. The individual answers to your questions may depend on the research evidence, your provider's clinical expertise, and your unique preferences as an individual and as a family. Now, evidence-based care all sounds great and wonderful. Doesn't it just sound like an awesome idea? Well, here's the problem. Very few people are actually getting this kind of care around the time of childbirth. And that's because we have something called the evidence practice gap. In the next podcast episode, we're going to dive into this evidence practice gap and talk about how difficult it is to get evidence-based care and why it's so difficult. In the meantime, I hope you enjoyed this episode all about what is evidence-based care. I'll see you next time. Bye.